Okay, so welcome everybody. My name is Jonathan Lovegrove. I'm one of the PMH EMS education officers for the region, and what I'd like to do is take a few minutes out of your time to go through the newly released OMD Care Map, Acute Coronary Syndrome. So let's take a look and see what's new. First thing we've got is we have a newly released streamlined care map from OMD, which is really nice, and we're going to take a look at that in a minute. Next big ticket item we should talk about is the fact that PCPs are now going to be able to administer intranasal fentanyl when patients have ACS type symptoms. So that's a really good addition. As well, I'm going to share with you some updated dosing guidelines for ASA. The next thing we're going to look at here is the change in systolic blood pressures in terms of nitroglycerin administration. So we'll go through that. And then the last thing we're going to talk about briefly here is we're going to talk about fluid bolus for these patients that are hypotensive, either because they are hypotensive with ACS or because we made them hypotensive. So let's take a look at the care map. Alright, so E04.1a, let's take a look through the new Acute Coronary Syndrome Care Map from OMD. First things first, ensure oxygenation. As per memo for all PMH staff, our oxygenation goal, or our SpO2 target for these patients, is 90% and above, and that's in line with ACLS guidelines. If the patient's short of breath, then please go ahead and administer oxygen as required. The ASA now has variable dosing guidelines. So anything between 160 and 325 is considered a therapeutic goal, and all of it would be acceptable to administer to your patient. So anything within that framework. The other thing that changes here is that you do not have to re-administer the ASA if your patient has taken in the last 24 hours and you are able to verify that that has happened. If you are unsure or unclear as to what the patient took or when they took it, please just go ahead and re-administer the ASA following the dosage guidelines that we have here. 12 leads are something that PCPs are able to obtain, but are not required to and are not expected to be able to interpret, and we don't want you to make any decisions off of what you obtain through your 12 lead at this point. We simply want you at the PCP level to obtain a 12 lead. So whether you're PCP or ICP, the target goal generally accepted is within about 10 minutes of initial patient contact that you'll obtain a 12 lead. ICPs may consider obtaining a 15 lead, and the rationale for that for an ICP would be that they're curious to see what's happening in the right ventricle and as well in the posterior leads. For ICPs, this information is for you only, but if you see elevation in V4R of more than 1 millimeter, which is one little box on your ECG charting paper, then that would be confirmation of an RVI, and you would want to withhold any nitrate and morphine therapies. PCPs, you're not allowed to do this. You just simply acquire and move on. Code STEMI bypass, we are outside of the Winnipeg and area, so this is only for units that are within 120 minutes of Winnipeg and can get to the desired facility, and simply geography just doesn't work in our favor here, so we're going to skip that. Then we come to administer sublingual nitroglycerin. What I'll say to this is that EM techs, PCP, and ICP all start with sublingual nitroglycerin for patients that have ACS type symptoms. Nitro is something that we would consider to be more of an optional / maintenance type issue. But we want you to be more aggressive when you have these patients, and that's something that you're able to achieve that outcome when you have sublingual nitro spray. You're just giving a higher dose more frequently. We see nitro patches as being more of a maintenance type issue. Once you've got the pain under control and you want to just keep that pain down to 0, then a nitro patch becomes a really good idea. What you won't find in this is how you actually move through the protocol. At what point do you move on? So generally accepted guidelines are that after about 3 sprays of nitro, if the patient still has pain that is unrelieved, that you will then move on to an opioid. In PCP's case, you're now going to have the ability to be able to administer intranasal fentanyl. There's one new contraindication or adjustment: systolic pressure less than 90. If it's less than 90, you're no longer able to administer nitroglycerin. So that's a change from 100 from before. Think about IV access for these patients if you haven't already achieved that or got that. And then we come down, and has the pain been relieved with nitroglycerin? It's quite reasonable to assume that you were able to treat the patient effectively with 1, 2, or even 3 sprays. If that's the case, continue to monitor and care for them during transport. If after 3 sprays and their pressure is still above 100 millimeters mercury systolic, you might want to consider intranasal fentanyl at the PCP level. And we're going to go over the dosing in a bit here. What we will say is that injectable fentanyl is a better option than intranasal. So I've mentioned here that there are drawbacks to intranasal fentanyl, and yes, that's true. The onset of action time for intranasal fentanyl, if everything goes absolutely perfectly right in terms of the administration, takes likely 5 to 10 minutes, whereas injectable fentanyl takes effect immediately. So if there's an option with a PCP, ICP crew, and there's an ICP on scene, the preferred method is certainly injectable. If during the course of your treatments the patient has become hypotensive, then what you're going to want to consider is small amounts of fluid to try and correct the situation. So we're not going to do the 1 liter bolus and then just reassess. We're thinking 5 to 10 mLs per kg to a max of around 500 mL. So really small amounts, really not stressing or straining that heart any more than it already is. The nitro dose for, or actually looking at the nitro care map here, the dose doesn't change, the indications don't change. The only thing that changes here is the systolic blood pressure has to be above 90 millimeters mercury in order to go ahead and administer the medication. Important to note here is that the nitro medication page is not changed at this time. However, please be aware that for all cases where nitro can be given, so for the congestive heart failure, as well as we've just talked about here for ACS, the minimum pressures that you can administer nitro is 90 millimeters mercury, and that's across all cases where you give nitro now. The dose, it's unchanged. It's still 0.4 milligrams every 5 minutes as required. The topical doses are applied in the ACS setting just as required. So you can do it initially or you can do it later on, but the patches are applied according to the patient's systolic blood pressure. So if the patient's systolic blood pressure is 180, then you would apply 0.4 worth of patches. But again, I want to stress that our main goal when we're giving nitro is to be a little more aggressive, and that's something that we can achieve through the spray format versus the kind of the slower method of the nitro patch. If you look at the nitro patch every hour with a 0.4 milligram patch, you're getting 400 micrograms per hour, whereas if you gave a sublingual spray, you would get 400 micrograms every 5 minutes potentially as required. So we're really able to treat more effectively and quicker with the sublingual dose, so it is certainly preferred. This here I've got clipped to the top of the page here is part of the information that's included in the OMD Care Map for ACS. So this is in the notes page. And I just want to draw your attention to, because there's a bit of issue with that, and we just want to clarify how to interpret this. Basically what this says is if the systolic blood pressure decreases below 90 millimeters mercury or by more than 30 millimeters mercury from the initial or baseline readings after giving nitro or opioids, that you are then to stop all treatments. So we want to just change that and adjust. Our interpretation for PMH is going to be that if the systolic pressure drops below 90 millimeters at mercury at any point during treatment, nitro is then contraindicated. So give them some fluids, small amounts of fluids. And if the hypotension, once it is resolved, use an opiate with caution. So you have intranasal fentanyl. And intranasal fentanyl, or fentanyl in general, is not going to likely cause a drop in blood pressure. Very minimal. The next thing here in terms of clarification for that point there, if it is anticipated that the administration of nitro is going to lower the blood pressure below 90 millimeters mercury, then it's reasonable to consider an opiate instead. So if you had given maybe one dose of nitroglycerin and the blood pressure initially was 110 and now it's down to 94, you would assume, based on that math, that your next dose of nitro would drop the patient below the 90 systolic blood pressure threshold. So perhaps consider moving to fentanyl sooner, and that's okay. We just don't want you to stop treating patients once the systolic pressure drops below 30 automatically. We just want you to keep in mind what the minimum systolic pressure should be and to continue treating those patients as long as they have pain. ASA. Again, there is really not a lot of change, so I'm just going to draw your attention to the one thing that has in fact changed to this, and that's simply the dosing on this. As I mentioned earlier, 160 to 325, anywhere in there is within a therapeutic range, so you're okay to administer within that dosing range. If the patient has taken 160 milligrams of ASA within the last 24 hours and you can verify that, then you don't need to repeat. However, if there is any uncertainty on your part as to what they took, when they took it, etc., then it is completely okay for you to just re-administer between 160 and 325. And here we have the intranasal fentanyl dosing. I've just clipped that out and nothing else here. So the guidelines for you, basically you can go up to 1 microgram per kilogram to a max of 50 mics per dose. You can repeat that every 10 minutes for patients less than 75. For adults, I should say, less than 75. And then for patients that are older, you really want to give them smaller doses. And that's just because the medication is going to impact them a lot greater than it will for somebody that's a little bit younger. So up to 0.5 micrograms per kilogram and a single max dose for geriatrics of 25 mics. That's it, everybody. We've made it to the end here. So if you're listening to this now, we can almost guarantee that we've already gone live with this protocol. The implementation date is December 1st of 2018. Just a reminder, if you haven't already done so, click that you've read the memo once you've read the memo and or once you've viewed this and you're comfortable. If you're not comfortable and you have any questions, as always, please contact one of the EMS education officers and we would be more than happy to be able to help you with whatever questions you have. Okay, thanks everyone again, and hopefully you found this useful and informative.